So what I'd like to do now is review some of the clinical studies that have been done, which really provides, I think, very strong support for the use of PK-guided dose monitoring of 5-fluorouracil. I think the group that has really played the most active role using this approach has been Dr. Eric Gamelin and his colleagues in France. And so this was a paper that was published in 2008 in the May issue of the Journal of Clinical Oncology. And what Dr. Gamelin and his colleagues did was they conducted a randomized, multi-center phase 3 study incorporating 17 different cancer centers in France. So this was in patients with metastatic colorectal cancer in the frontline setting. And patients were randomized to either Arm A, which was the traditional conventional BSA dosing of 5-fluorouracil, versus Arm B, which was to give the very first dose of 5-fluorouracil based on BSA dosing, but all subsequent doses of 5-FU were adjusted to achieve a target AUC concentration. And at that time, Dr. Gamelin used the AUC of 20 to 24. And that was based on his reading of the literature, suggesting that if you were below an AUC of 20, that was associated with reduced clinical efficacy, and that in patients who were above an AUC of 24, that was associated with increased toxicity. Now, one of the potential criticisms of this study was that they used a somewhat funky dosing schedule of 5-fluorouracil. So it's 1,500 milligrams per meter squared, given over an 8-hour period, administered on a weekly basis. The primary endpoint of this study was overall response rate. Secondary endpoints were duration of treatment, overall survival, and tolerability and/or safety. What you see here on this slide is that obviously in patients who were randomized to the conventional BSA-based dosing approach, Arm A, the vast majority of patients received 1,500 milligrams per meter squared, and then a smaller number of patients were dose reduced as a result of increased toxicity. In Arm B, what you see is that in fact there's a wide range of 5-FU doses that were administered based on 5-FU AUC drug levels. And in fact, the mean dose for those patients randomized to Arm B was actually greater than 1,500 milligrams per meter squared. In fact, was 1,814 milligrams per meter squared. I think what was most impressive about this study was that 85% of patients randomized to Arm B required dose modification of the 5-FU dose. In fact, 68% required dose increase and 17% required a dose reduction, which means only 15% of patients who were being treated on Arm B were actually in the so-called sweet spot. And that's actually a very, very, very low number. I think the other point to make is, I think a lot of people say, well, I know how to give 5-FU because if someone runs into toxicity, I can just dose reduce. But I think the importance of this slide is that almost 70% of patients require dose increases, which means that almost 70% of our patients aren't getting effective doses of 5-fluorouracil. Now, despite the increased doses in those patients randomized to Arm B, there was a significant reduction in overall grade 3, grade 4 toxicity in those patients randomized to the PK-guided dosing arm. And if you look more specifically at the incidence of grade 3, grade 4 diarrhea, was significantly reduced from 18% to 4%. If you look at overall response rate, which was the primary endpoint of this study, it was nearly doubled in those patients who were randomized to the PK-guided arm, from 18% to 36 to 34%. And if you look at overall survival, so here we're looking at 1 year and 2 year survival respectively, it's increased in both cases in patients who were randomized to the PK-guided arm. If you look at median overall survival, it increased from 16 to 22 months. Now one could say, well, that was the increase in 1 year, 2 year median overall survival was not statistically significant, But again, this study was surely not powered to look at overall survival. And also, one could imagine that the subsequent therapies, second line, third line, were probably equivalent for both arms. And that would then dilute out the impact of the PK guided dosing of 5-fluorouracil. So, to me, actually, when you look at the reduction in toxicity, the improvement in response rates, and improvement in overall survival, that's pretty significant. Now, again, one criticism is, well, that was with just 5-FU alone and using a very different dosing schedule than we're used to. So again, the folks in France, Dr. Gamelin and his colleagues, followed that up using what we would consider to be more traditional FOLFOX chemotherapy regimen. So this was a phase 2 study, kind of a proof of concept study, using a conventional regimen that I think we're all used to. And again, normally for FOLFOX6, in this case, they actually use FOLFOX6, where traditionally the dose would be 2,400 milligrams per meter squared, using kind of a PK-guided dosing approach, the average dose that they ended up using was almost 2,800 milligrams per meter squared. So again, kind of using that sweet spot AUC of 20 to 24, they found that actually 80% of patients were not in that sweet spot. 50% of the patients were underdosed and required dose increase, and 30% were receiving too high a dose and they required dose reduction, which again meant that only 20% of patients were in that target range of 20 to 24. And that's pretty significant. If you look at the toxicity, and this was not a randomized study, so 118 patients were treated with FOLFOX using this PK-guided approach, and almost 40 patients were kind of treated, they were kind of viewed as control patients who were treated using a BSA-based dosing of 5-FU. You can see that the GI toxicity in the form of diarrhea and mucositis was significantly higher in those patients who were treated with the BSA-based approach. And if you look at overall response rate, it's increased from 46 to 70% in patients who were dosed using the PK-guided approach. And if you look at median progression-free survival, it was increased from 10 to 16 months, and median overall survival from 22 to 28 months. So I guess I would just say, first of all, this is a cross-trial comparison. It's not a true randomized study, but I think very consistent with what we just saw with 5-FU treatment alone. Toxicity is reduced in those patients receiving 5-FU based on a PK-guided approach, and response rates and overall clinical efficacy in terms of median PFS and median overall survival increased. Now, there's been kind of a clinical experience looking at 5-FU dosing in patients who were receiving FOLFIRI, FOLFOX, and FOLFOX plus the anti-VEGF molecule Avastin, using an assay, the 5-FU immunoassay that the folks at Saladex Biomedical have developed these last few years. So I guess maybe the first thing to note is that in the two previous studies that I shared with you, the initial Gamelin study published in the Journal of Clinical Oncology, and then the more recent study looking at FOLFOX that was published in Clinical Colorectal Cancer, the way that Dr. Gamelin and his colleagues measured 5-FU AUC drug levels was using HPLC, high performance liquid chromatography, which is a much more technically involved, labor intensive, requiring highly skilled personnel to be able to then measure 5-FU drug levels. And also because of the more sophisticated instrumentation, the turnaround time was actually much longer. So it took on the order of 7 days to be able to run the samples and then give the results to the practicing physician. So the beauty of this 5-FU immunoassay, which has been developed by the folks at Saladex, is that it requires a much smaller amount of blood samples, and the turnaround time is quick. In fact, if they run the blood samples in the morning, the results actually are obtained later on that afternoon and can be actually faxed to the individual practitioner later on that afternoon or early evening. So clearly more than enough time to then be able to make treatment decisions for the next cycle, which would take place in 2 weeks. Now, recently, Dr. Klein and colleagues at the Penn State Hershey Cancer Center published their experience at Hershey using the 5-FU immunoassay to monitor 5-FU AUC drug levels. And this was in patients with both early stage as well as metastatic colorectal cancer. So some of this was actually presented at last year's AACR meeting. So this was the experience at Penn State Hershey, 84 patients. Some had early stage disease, stage 2, stage 3 disease, for which they received adjuvant 5-FU-based chemotherapy. And then a number of patients had stage 4 metastatic disease. Obviously, the main regimens used for early stage disease was FOLFOX, and for metastatic disease, patients received either FOLFOX-based chemotherapy or FOLFIRI-based chemotherapy. 46 patients had dose optimization. So again, this was not a randomized study comparing head-to-head conventional BSA-guided dosing versus PK-guided dosing. Okay, so a bit of apples and oranges. So that's, I think, one thing to keep in mind. The main endpoints of this study were safety, toxicity, and in those patients who had early stage disease, disease-free survival, in those patients who had advanced metastatic disease, the main endpoint was progression-free survival. I think what you see here in this table, that in those patients who were receiving 5-FU using the PK-guided monitoring approach, that the GI toxicity was significantly reduced. 50% in those patients receiving conventional BSA dosing of 5-FU, and 16% in those patients who received FU using 5-FU AUC drug levels. Really no other differences as it related to myelosuppression. And again, if you look at overall grade 3, grade 4 toxicity, it was cut in half from 69% to 32%. Small numbers of patients, but I think certainly this data is very consistent with what has already been published to date. And if you look at the impact of monitoring 5-FU AUC drug levels, dose optimization, and the impact, potential impact on disease-free survival, again, you can see that patients who receive 5-FU using the AUC drug levels did much better. And this was statistically significant. Case is a 70-year-old female who presented with early stage 3 colon cancer, who was treated with modified FOLFOX6. And again, so this is the situation where one really wants to be able to optimize 5-FU drug levels because, again, right, in the adjuvant setting, we're going for the cure. Okay? So as you see here, in the very first cycle, where we're giving 2,400 milligrams per meter squared, the AUC drug level is 14, which is below the target range of 20 to 30. Based on the dosing algorithm, we increase the dose from 2,400 to 2,836 milligrams per meter squared. And what you can see then is for cycle 2, the AUC goes up to 21. Okay? Decision is made. We're in the sweet spot. We're not going to change the dose for cycle 3. We don't. And then what you can see is on cycle 3, with the same dose now of 5-FU, the AUC goes up to 26. At that time, the patient begins to increase some very, very mild oxaliplatin-associated cold-induced neurotoxicity. For cycle 4, we don't change the dose, and again, you see the AUC is 24. And that patient actually then is maintained on the same dosing schedule. And I have to say, in subsequent cycles, we've continued and maintained that dose, and the AUC has been maintained in that sweet spot of 20 to 30. So in this case, I guess the take-home message is, and our experience has been for the most part, that very first cycle, more than I think what has been published to date, we see pretty much all of our patients who usually present with a lower 5-FU AUC drug level. In this case, really actually all it took was just that one dose increase, and we were able to then maintain that patient in the appropriate 5-FU AUC target range. Please feel free to email me directly. My email address is chue2, so that's chue2 at upmc.edu.